Good evening to all doctors. I am thrilled to welcome you all for today's informative webinar on how to choose a fluid for intravenous fluid resuscitation. I am Vijay, manager at Mediversal Academy, and I have the privilege of introducing our esteemed speaker for the day, Dr. Rajesh Kumar Chand. Dr. Rajesh is a senior director and head of cardiac anesthesia and cardiac critical care at Max Super Specialty Hospital, Saket, New Delhi. He holds an MD in anesthesia and a PDCC in cardiac and neuro anesthesia, and is an honorary FIACTA. He has an extensive experience in cardiac anesthesia with surgical interest in off pump coronary artery bypass surgery, hemodynamic monitoring, and critical care. Dr. Rajesh has contributed to the field through 10 national and international publications and served as a reviver of the annals of cardiac anesthesia. He currently serves as Associate Vice President of IACTA and has previously held key roles including Secretary and Executive Council member of IACTA. He is also an FIACTA examiner and formerly served as Assistant Professor of Cardiac Anesthesia at AIIMS, AIMS, New Delhi. Over to you, Doctor.
Thank you, Vijay, for your kind introduction, and good evening to my dot- learned audience of doctors. Today, I'll be talking about how to choose a fluid for intravenous fluid therapy. Actually, the topic should have been therapy. I would be talking about intravenous fluid therapy, not only resuscitation.
Doctor, one small request. Can you please on the camera?
Uh, Camera,
Yes, yes. The cap of the camera is closed.
is it good?
Yes, yes, doctor, it is, it is.
I'm sorry, Vijay.
No, no, it's fine.
So this is the overview of my talk. I will talk what is the objective of my talk. I will introduce the subject, talk about the types of fluid, what are the indications of intravenous fluid therapy, why should we do intravenous fluid therapy, and what are the signs and symptoms of signs, symptoms, and laboratory findings of a patient who will need intravenous fluid therapy, or the patient who will be deficient in IV body fluids. Then we how to go about choosing an IV fluid. We will talk about some special situations, specific and special situations, and some take-home message. Today, my objective is to tell you all about the how, why the fluid therapy is important, how important it is, why and how, and to understand the challenges which are there in choosing what is the best fluid. To look at the types of fluid available, to talk about some generic consideration in relation to fluid therapy, and to talk about choices of fluid in specific and some special situations. My introduction will be, I'll introduce the topic in this form, that why, to understand the importance of fluid therapy, we need to understand why the fluid, which contains water predominantly, is important for us. What are the intrinsic factors which are impacting the in vivo water dynamics in the body? Because the water in our body keeps moving between intracellular to extracellular and intravascular, because total body water is 60 liters of body water in an average adult, and our intravascular compartment contains only 5 liters. So there is a continuous dynamic movement of water, and what are the factors which are impacting it, because they will be very important in modulating and influencing our fluid therapy. What are the challenges in giving fluid therapy, like how to choose which fluid therapy? What are the challenges in monitoring the fluid therapy, and challenges relating to evidence? And then in the introduction only, I'll talk about what are the goals and what are the common fluids. So water is the universal solvent and most essential nutrient. It is so obvious. In the blood vessel, water, the function of water is to transport oxygen, solutes, and hormones to the institution and remove the waste products. In the interstitial space, the water is responsible for the movement of all these above mentioned substances between the capillary and cells. And in the cells, water is the medium through all reactions and interactions happen, and it's also important for to maintain the structural integrity of the cell. Water is involved in the temperature regulation of our body, and in sick patients who need fluid therapy, restoring and maintaining all this fluid balance can be a very difficult challenge. Now, looking at the intrinsic factors which impact the in vivo water dynamics, the movement of fluid occurs in these compartments. There is intracellular compartment, extracellular compartment. Extracellular compartment consists of interstitial and intravascular compartment. And the factors which are responsible for these movements are transmembrane hydrostatic pressure, colloid oncotic pressure, endothelial glycocalyx structure and its function, and endothelial membrane integrity, cellular membrane, and lymphatic function. And the fluid composition which we give to the patient and the volume of the fluid infused will change the hydrostatic pressure. So this is what we have to understand. And this fluid composition and volume will also change the colloid of osmotic pressure and extracellular fluid osmolarity. So thereby changing the volume kinetics of the distribution. Now, choosing fluid, why it is difficult? Because it is obviously a critical aspect of patient care. And each patient, it's very difficult to have a universal guideline because patients will have unique needs based on their age, based on their diverse medical condition like congestive heart failure, liver or kidney diseases, to name a few. There is a whole bunch of them. The specific type of the patient can have different types of fluid losses, like dehydration, loss because of surgery, trauma, burns. Then patient's ability to maintain fluid intake. Patient is able to take orally, or patient is able to not take orally and can need only IV fluid. Then why we need to monitor fluid therapy? Because monitoring of fluid therapy can help us to either start fluid therapy. This monitoring can help us give the start, stop, and change triggers for fluid therapy. But the limitation of monitoring is that intravascular samples are poor representative of total body water. As I told you, total body water is 60 liters. And intravascular is only 5 liters. Whatever sampling we do, blood gases, laboratory test, all the values which we get is in the 5 liter of water, and they may not necessarily represent the intercellular composition because the transport between water between the compartments may have changed or hampered. So this is the challenge. And of the alteration of intrinsic factors, especially in critical patients, will change these dynamics. And then there are no universal guidelines. That's the problem with the evidence. Really, there are not many RCTs which tell us that give us algorithm of fluid to use. There are RCTs about use of normal saline and balanced crystalloid solutions, individual blood product, but there's no algorithm that these are the diverse fluids which we should use in specific conditions. The core principle of fluid therapy is to replenish the identified fluid losses, which will vary in volume and composition and with patient's underlying condition. The goal of fluid therapy is to maintain. The goal can be maintenance, replacement, or resuscitative therapy. In maintenance, we give the daily, we just replace the daily fluid losses in an otherwise normal patient. The fluid losses which are from urine, respiration, sweat, and stool. Now, in replacement therapy, besides maintenance, what we need to replace whatever fluid deficits are there because of illness or because of injury, like surgical injury or trauma or burn or third space shift because of inflammation. Then there is resuscitative therapy, which is required in hypovolemic when the patient is having hypovolemia or shock-like state. The commonly available IV fluids are crystalloids, which may be hypertonic, isotonic, or hypotonic, and colloids, like natural colloids or synthetic colloids. Crystalloid solutions are aqueous solutions. They contain water and different types of solutes like electrolyte and glucose, and they can be hypotonic, isotonic, or hypertonic. Tonicity is the effective osmolarity. It governs the ability of fluid to alter the water movement across the cell membrane. And fluid osmolarity may not equate to tonicity. But for example, A fluid may be isoosmolar but yet hypotonic. Hypotonic colloids, they have effective low osmolarity. They reduce the osmolarity of extracellular fluid, and they result into redistribution of water into the intracellular compartment. Specific types of fluids are 5% dextrose, 0.45% saline, sterile water, and their uses are maintenance fluid requirements for treatment of solute-free water deficits and for dilution of drugs for drug administration. Isotonic colloids have effective osmolarity of plasma, which is 270 to 310. Their sodium concentration is similar to that of extracellular fluid, and these isotonic fluids can have varying concentrations of different electrolytes like sodium, chloride, potassium. Sorry, it's a typing error. It's a magnesium and calcium. They can also have organic ions like lactate, gluconate, and acetate for the purpose of provision of carbonate. We don't have carbonate as an ion because it's difficult to maintain carbonate, it dissociates. So instead of carbonate, the fluids can have these lactate, gluconate, and acetate organic ions. The electrolyte and isotonic fluids are similar, the concentration is similar to plasma. They maintain or normalized acid-base balance through their strong intrinsic acid deficit, and isoosmotic. They are isoosmotic and isotonic to normal plasma. Example of isotonic crystalloids are normal saline, lactated ringer solution, and there are other balanced crystalloids like plasmalite, cabalite, sterofundin. These are all proprietary names. The use of isotonic crystalloids are to replenish extracellular fluid deficit, to maintain extracellular fluid volume, and the distribution of these isotonic crystalloids will be altered if there is a change in crystallite oncotic pressure. If you remember the intrinsic factors we talk about, the distribution will also be altered if the vascular permeability is altered or there are changes in extracellular matrix. The 50% of the intravascular volume effect which we achieve by isotonic crystalloids is lost in 30 minutes if the capillary fluid dynamics are normal. And if the transcapillary fluid dynamics are deranged, then this all fluid can be lost in less than 30 minutes. Hypertonic crystalloids they have effective osmolarity. Their effective osmolarity is higher than that of plasma. They increase the osmolarity of extracellular fluid, and that is why they cause the redistribution of water out of the intracellular fluid, and thereby they increase the extracellular volume. They are used for customizing crystalloid fluid solution to target a desired sodium concentration or to cause forced diuresis like use of mannitol. And their effect is that they increase the plasma osmolarity, they increase in sodium and chloride concentration. They also cause endogenous release of vasopressin and they cause immunomodulation. Colloid solutions are now coming to colloid solutions. They are large molecular weight proteins or hydroxyethyl starches in crystalloid solutions. They do not cross endothelial glycocalyx and membrane easily, and that is why they increase their oncotic pressure. Natural colloids are protein-containing products like whole blood, plasma, and albumin. Albumin has maximum water holding capacity. It has antioxidant properties, and it's a carrier of proteins in the body. Other natural colloids are FFP, fresh frozen plasma, cryoprecipitate, platelets. And the choice of these natural colloids will depend on what is the coagulation status of the patient and about the product availability with that healthcare system and the patient resource availability. Because, for example, albumin can be very expensive. Now, coming to synthetic colloids are gelatins, starches, dextran, and complex polysaccharides. Gelatin and dextrans are infrequently used. Hydroxyethyl starch, they are most common. They are polymer of glucose, 98% amylopectin, and they are made from plant starches such as maize, potato, and sorghum. And they vary in their molecular weight. The clinical effect of colloids are the clinical effect of colloid, including their half-life and coagulation effects. They impact the colloid oncotic pressure and the volume expanding effect. For example, if the volume, the half-life is long, then the colloid oncotic pressure will be increased more. And if the molecular weight is large, then the volume expanding effect will be more. But if the half-life is longer, then the patient will have coagulopathy also by diluting the procoagulants. And the main characteristics of the colloids are their concentration, like what crystalloid concentration they are dissolved in, their molecular weight, their molar substitution, and their C to 6 ratio. These characteristics determine what will be the half-life of the colloid, that synthetic colloid, and what will be the volume expanding effect of that colloid. In hydroxyethyl starches, the degree of volume expansion and their half-life in the blood is difficult to predict. In normal people, normal test subject, we know that this colloid will last for this much time and this will be the um, volume expansion effect. But if in sicker patients, either because of inflammation, trauma, or body other physical illnesses, depending on the degree of vascular injury, molecular weight of the starch, dispersity, this amylase concentration, elimination rate into urine, electrical charge, and the effect on endothelial glycocalyx, of effect of the disease. All these factors will alter the half-life and volume expansion effect of the colloids, in particularly in critically ill patients. And most important alteration will come because of the changes in capillary permeability because of vascular injury. The indication of fluid therapy can be resuscitation, rehydration, and maintenance of fluid. The indication is all of the fluids are also required to dilute the drugs for drug administration to maintain the catheter patency. And the patients who require resuscitation, they are hemodynamically unstable, and we use fluids to address acute volume loss or intravascular volume depletion. Whereas rehydration corrects the ongoing or pre-existing deficit. And maintenance fluids are given to patients who are hemodynamically stable, but they are unable to meet their daily fluid and electrolyte requirement. Now, we'll just look at what are the symptoms of volume depletion. The earliest symptoms of volume depletion, which will tell us that patient needs fluid therapy, are fatigue, thirst, decreased urine output, and dizziness. And if this volume deficiency, this depletion continues, then the patient may have experienced abdominal pain, chest pain, and confusion because of decreased cardiac output and ischemia. Patient may also develop muscle weakness because of hypo or hyperkalemia. Patient will have tachypnea because of acidosis, confusion, seizures, and lethargy. Patient may also have metabolic alkalosis and hypo or hypernatremia. The physical parameters used to assess volume status are body weight, it is highly sensitive, and regular monitoring of weight fluctuations can tell us that can indirectly tell us about the volume fluctuations in the patient. But the problem in using patient as a weight as a parameter, because the hospital weighing scales, they vary, and we need to have either use same weighing scale or standardized scales, because 1 kg loss here and there, 1 kg loss or gain may mean patients have deficient in 1 liter of fluid, or maybe 1 liter fluid over hydrated. But then small 1 kg difference, we will not be able to track if the different machines are used. So other parameter is heart rate. Tachycardia will be there as a compensatory response. The early sign of compensated hypovolumic shock may be there, all the early signs. But then we have to rule out other causes of shock, like cardiogenic shock or septic shock. Blood pressure is the physical parameter to assess volume status. There will be decline in blood pressure. Now there may be orthostatic vital signs that blood pressure will fall by 20 systolic or 10 diastolic in 2 to 5 minutes of standing after resting supine for 5 minutes. The respiratory rate will be more than 20 breaths per minute, and there will be fall in urine output. It should normally in output should be 2 ml per kg per hour in neonates, 1.5 in children, and at least more than 1 ml in adults. Other signs of volume deficiency can be seen from capillary refill. Normal capillary refill occurs in 2 seconds or less. Then from sunken fontanelle, we can see hypovolemia. Peripheral edema can tell us about volume overload or third spacing, and tear production, especially decreased tear production in tells us about volume deficiency. It's more so in children and infants. Peripheral pulses are often fast and steady. Skin turgor and eye appearance, skin turgor will be lost, eyes will be sunken, and in severe cases of dehydration, there may be flaccid skin. Skin will be maybe cool and clammy, and the mucous membrane will be dry and sticky. Jugular venous pressure, obviously, if we are monitoring central venous pressure, it will be low, and in hypervolemia, the jugular venous pressure will be high. Laboratory finding: in dehydration, the blood urea nitrogen to creatinine ratio is elevated. There may be elevation of transaminases because of hepatic tissue hypoperfusion and hepatocyte injury. We may find concentration, and additional parameters may be elevated serum urea, osmolarity, sodium, urine osmolarity, and specific gravity. Now, coming to choosing an IV fluid. Fluid choice is important because IV fluids are the most commonly prescribed medication in hospitalized or critically ill patient. The optimal choice of fluid remains poorly defined. The fluid choice can have an impact on outcome, particularly in critically ill patients. And the problem is that specific recommendations, what is the best type of crystalloid and colloid fluid to infuse, cannot be based on the current information. The factors which will help us to determine which fluid to use, that they are what volume of distribution we want to use, what is the electrolyte and acid base status of the patient, what is the disease factor, what are the disease processes, and this will also depend on fluid factors like, as I've already told, tonicity, electrolyte, organic ion concentration, and compatibility with the drug and other fluids. In absence of any universal guideline, there are some fluid stewardship. So 4 rights of fluids are right drug, right dose, right duration, and right patient. This minimizes the risk of volume overload, cerebral edema, hyponatremia, or hypernatremia. Fluid selection it's an ongoing assessment. Fluid selection and ongoing assessment is critical to ensure the safe and effective fluid management. Some other considerations are: we avoid hypotonic solution in hyponatremic patient because that can cause cerebral edema. We want to use controlled hypotension or permissive hypotension, especially in patient of trauma. And here the aim is to keep the systolic blood pressure just above 70. Why we do this? Because if we try to achieve normal blood pressure, we want to achieve normal fluid dynamics, then we will have to infuse a whole lot of more fluids, which will cause dilution, which will cause dilutional coagulopathy, disruption of thrombus formation, and worsening of hemorrhage. So that is why we give less than optimal fluid and accept suboptimal situation, particularly in trauma patient. But we avoid control hypotension in patients who have trauma and brain injury, because in brain injury, if we do control hypotension, then patients neurological injury will set in. There we need to fully optimize the patient. Then fluid administration is avoided or carefully balanced in cardiogenic shock, congestive heart failure, renal failure, and patient with increased intracranial pressure. The most commonly used fluid types are 0.9% saline, 0.45% sodium chloride is half normal saline. Lactated linger solution, 5% dextrose in normal saline, 5% dextrose in half saline, and a whole range of balanced crystalloid solutions. Now, talking about replacement versus maintenance fluid. So, we use maintenance fluids to replace solid free water and electrolyte losses in otherwise healthy patients. And the composition of those fluids is similar to that of plasma. Whereas replacement fluids are isotonic crystalloids, they replenish the extracellular fluid deficit and replace ongoing losses. So theoretically, it looks that we need to use two types of fluids, but we don't, because these fluids are almost similar. And duplication of fluids can increase complexity and patient cost also. So replacement and maintenance fluids are used interchangeably, and for this purpose, isotonic crystalloids are good enough. But challenges of using isotonic crystalloids are, they, as I've already said, that the 50% of volume effect of isotonic crystalloids is lost in less than half an hour. And in sicker patient, it may be still faster. So they provide ineffective intravascular volume support. After some time, all this volume will go into the extracellular interstitium or in the cells. Then they may cause hyponatremia, acute hospital-acquired hyponatremia is caused by hypotonic maintenance type of fluid. And our RCTs have shown that isotonic crystalloids are safe and they cause lower incidence of hyponatremia. IV fluid therapy also involves consideration of various electrolytes. For example, sodium concentration. These isotonic fluids, they have wide range of sodium concentration. And the sodium concentration may be from same as a plasma to from 135 to 145 milliequivalent. And in lactated ringer solution in plasma light. So lactated ringer solution is an ideal fluid in an otherwise normal patient. But if the patient is hyponatremic, then we need that is sodium less than 120. Then we don't need to use. Then we should not be using lactated ringer, and the best solution to be used will be normal saline. So all these things we have to consider, that when we are using sodium containing fluid, which fluid to choose, normal saline or lactated ringer, that will depend on the patient's sodium. Then the chloride concentration is important. Normal saline and hydroxy starch in normal saline, their potential adverse effect is hyperchloremia if we infuse them in large volume. So that is why if we use balanced colloids, crystalloids, we don't have chloride. They in a larger volume also will not cause hyperchloremia. And that is why they may have lower mortality rate, lower rate of renal replacement therapy or renal dysfunction in critically ill patient as compared to saline administration. But in non-critically ill patient, there is no difference in outcome. And fluid retention also is more with normal saline in the interstitial space as compared to the balanced isotonic solution. Now, talking about potassium concentration, 0.9%, like normal saline is recommended in hyperkalemia, and potassium hemostasis also depends. It depends on the extracellular sodium concentration and potassium concentration also, and sodium and potassium exchange. So, studies have shown that if you use 0.9% saline as compared to balanced solution, we may end up having similar or higher potassium concentration. Why I am telling you this? Because intuitively it looks that if patient is having hyperkalemia, we should be using normal saline and not balanced crystalloid, because balanced crystalloid have contain potassium. But that is what studies have shown, that if since the homeostasis not only depends on sodium and sodium concentration, it also depends on potassium concentration and sodium and potassium exchange. So up to moderate amount of infusion of balanced crystalloids, the sodium concentration will not rise significantly. Whereas on the contrary, if we use a normal saline in these hyperkalemia patients, patients may have hypercholoremic metabolic acidosis. So we really have to balance which fluid to use in presence of hyper patient who are having acidosis and to avoid hyperkalemia. Magnesium concentration we need to see, because hypomagnesemia will be there in the patients who are on ventilator, who are having long ICU stay. And other information is that magnesium containing fluids are compatible with blood products. Regarding calcium, lactated ringer contains a small quantity of calcium. It is thought that we should avoid co-administration of ringer lactate with blood product, but studies have shown that ringer lactate is safe to co-administer with blood transfusions. Then these fluids can have acid-base effects. Like crystalloid fluids are acidic in nature, and but in the amount they are used, usually they will not significantly alter the acid-base balance of a patient. And I've already talked about hyperchloremic metabolic acidosis. This will come as from the administration of large amount of normal saline. Now, IV fluids contain organic ions like lactate, gluconate, and acetate for the provision of biocarbonate in the body. And the metabolic, these metabolism of these organic ions, this will increase the plasma bicarbonate concentration in a dose-dependent manner. And this can also promote development of metabolic acidosis. About lactate, rapid administration of large volume of lactated solution will result into blood lactate, and that can confuse the assessment of hemodynamic status, because in our blood gases, higher lactate means patient either may be having sepsis or poor perfusion, but this interpretation may be confounded if we are using large amount of ringer lactate. That is why ringer lactate has gone out of fashion. And also the metabolism of lactate occurs primarily in liver, so we should avoid lactate containing fluids in liver dysfunction. And in place of ringer lactate, we can use ringer acetate, which is rapidly metabolized by extra hepatic tissues. We can also have dilutional acidosis. The fluid therapy can cause dilution, and we give large amount of IV fluids. This will result into extracellular volume expansion, and that is why the fluids balanced solution have carbonates, because otherwise, if you are using fluids like normal saline or ringer lactate, we don't have. Ringer lactate will change into carbonate. So, but non-carbonates fluids, if you are using, the volume expansion will be there, and bicarbonate concentration will fall, and that is why dilutional acidosis can occur. But it occurs only after rapid administration of large amount of fluids. Now, just a bit of fluid osmolarity. This is a slightly busy slide. I'll go slow on that. Fluid osmolarity. Osmolarity is a measure of total concentration of solute in a quantity of solvent. Osmolarity is number of osmoles per liter of solution. In most clinical scenarios, milliosmoles per liter is equivalent to the milliosmoles per kg, and terms are considered interchangeable. Hyperosmolar fluids, the examples are like sterile water, they can create injury. And in the peripheral vessels which are small, we to avoid phlebitis, the infusion of hyperosmolar fluid should be done through a central line, or at least large vein. Now, galactomannan is there in plasma light, and if we use plasma light, then if we do a serum galactomannan to diagnose aspergillus, then the sample may give false result. Talking about fluids for medication delivery, we can pretty much use any crystalloid, but typically 5% dextrose or normal saline is used. They are not complex, they are acidic and less likely to alter the medication. And which fluid to use for dilution of drug is given in the prescribing information. Balanced isotonic crystalloids can be given with many medications. The exceptions are plasma light is incompatible with pantoprazole, cyclosporin, and midazolam. Ringer lactate is incompatible with diazepam, ketamine, and cyclosporin. Now, last but not the least, coming to some specific and special situation, how to choose fluid. If the patient is fasting, then perhaps simple dextrose saline solution is good enough. Or depending on patient's sodium concentration, we can use dextrose saline and normal saline plus normal saline oblique crystalloid balanced crystalloids. This will all depend on how much amount we want to use. And if the patient is diabetic, then they will be need to add insulin. If the patient is having diarrhea or dehydration, if it is mild diarrhea and dehydration, the same fluid choice I will suggest. If there is severe diarrhea or dehydration, then we need to use balanced crystalloids, and we may need to supplement or manage the electrolytes on the basis of ABG, acid blood gases, and lab findings. For intraoperative losses, if there are short procedures, minimum losses, balanced crystalloid solutions are good enough. But long duration surgery or major losses, then balance crystalloids, and we should consider normal saline if the patient is having chronic kidney disease or hyperkalemia. And balance crystalloids or normal saline plus dextrose water in small dose all along. This is to meet some small glucose requirement and to suppress catabolism. Uh, Synthetic colloid we can use like hydroxyethyl starch, 500 to 1000 ml, depending on patient's height and weight size, and particularly, but I will suggest that we should use in the initial part of surgery, because in the later part of surgery or in ICU, once the stress of surgery and inflammation kicks in, with the inflammation there is a change in capillary permeability, and this all these colloids, including hydroxyethyl starch, albumin, they will lose their volume effect, and they will become almost like crystalloids, and they will almost immediately go into the extravascular compartment if the patient is in an inflamed state, which will result either in the later part of surgery or in chronically sick patients, or in patients of trauma, or in post-operative situation. We should consider albumin if the surgery is major and there are significant blood losses, and plus correction of electrolytes depending on lab findings. Continuing intraoperative blood loss, up to 10% blood loss, crystalloids are good enough, and we can consider hydroxyethyl starch 500 ml. But even with this 10%, we should consider blood if the patient is elderly or small size, if the patient has had long ICU stay, severely undernourished, or anemic patient. If the blood loss is more than 10%, we should use replace blood, and how much blood will be guided by the hemoglobin and the patient's hemodynamics. For example, even if the hemoglobin is 10 and our CVP is good, we have given enough fluid, blood pressure appears normal, but if patient is having tachycardia, we should consider giving blood, because that may settle the heart rate. So similarly, hemodynamics and hemoglobin will help us know when and how much blood to give. And the use of product will be guided by the clinical evidence of increased medical bleed or thromboelastography. Because if there is a large volume loss and we replace blood, then the patient will have dilutional coagulopathy, because the blood which is given is uh, uh, like concentrated red blood cell. It will not contain clotting factors. So if we use 4 or 5 units of this blood, then that means lot of clotting factors are lost and patient may have coagulopathy. That there the need for blood products will come in. Now coming to trauma patients will need balanced crystalloids. Electrolyte correction will be based on laboratory finding and blood gases. They will need the use of hydroxy style starch is questionable. It can be used, but they're keeping in mind the concern for the kidney and coagulopathy if the large volumes are used. Albumin and blood product, as I said, albumin can be used, but again, volume effect, we are not very sure, because patient may be having inflammation. Blood and product will depend on hemoglobin, hemodynamics, and other coagulopathy like thromboelastography. Burns patient, we need to use balanced crystalloids, albumin. We should not use hydroxyethyl starch because significant burn likely to have kidney impaired kidney function and kidney injury. Blood depending on their hemoglobin and correction of electrolytes. Now, at the end of the day, this is how I can summarize that best choosing and best IV therapy can be very overwhelming. It can appear confusing. There are no guidelines, and fluid choices will depend on existing acid-base status, electrolyte condition, and more importantly, specific patient conditions. Different conditions, it will depend. Thank you. Thank you for your attention, and I'll be happy to answer all the questions which are there.
Okay, yeah, thank you, doctor. Thank you, doctor. Thank you so much.
Sure, sure, Vijay.
Yeah, doctor, if you can open the feedback form, QR code slide, I'll continue my.
I'll do that.
Yeah, yeah. Hi, doctors. Thank you. Please do scan the QR code and to submit the form to get your certificates. Uh, and also, Q&A session is open. You can drop your questions so the doctor would be able to answer your questions. Dr. Dinesh, yes, I'll drop the link. Doctor, I think we have few questions. If you can able to see the chat box, or else I'll read it out for you.
Can you read the? I'll go to chat box and see because I'm still sharing my screen.
Yeah, yeah.
Shall I unshare my screen?
Yeah, yes, doctor, you can unshare. You can stop sharing.
Okay. So chat box. Yeah, I'm not very tech savvy, so
No, no, no
chat
worries, no
box.
worries. I can read it out for you. Okay,
Yes.
it is there. You can see the chat box. Yes.
Uh, can you read? I'm still not seeing it.
Yeah, I'll read it out for you, doctor. 1 second. Uh, okay, there are no question actually. They're telling really tough, sir. Thanks a lot. Dr. Twinkle is saying thank you so much, sir. Nice session. Really it is necessary in ICCU management. Dr. Shashi Sharma says wonderful session, sir. Thank you for the explanation. Then there are no question, doctor. They are just giving their feedback.
Okay.
Doctors, I have given the chat certificate link in the chat box and I'm dropping it again. Please do fill the form and to get your certificates. And meanwhile, you can also drop your questions so the doctor can be able to answer you. Doctor, there is one question.
Sure.
How does RL and RA differ in fluid resuscitation in burn?
Actually, as I said, uh, there are similarities and dissimilarities. RL is ringer lactate and RA is ringer acetate. So their composition is essentially similar, except that to provide bicarbonate, there is a lactate which in the intravascular compartment will degrade into will help to provide bicarbonate, and in the other solution is acetate. The difference will be in burn, the patient will have either acidosis. So lingual lactate can cause lactic acidosis, And if there is a liver injury, that liver injury also, we should not be using a lot of lactate, because lactate is metabolized in liver. So these two problems are there. Otherwise, uh, like number more, I don't really first hand manage a burn patient. I'm a cardiac anesthetist and a intensive care provider for cardiac patients. But this is what I could understand from whatever I've read, that essentially there will not be much difference. A small amount, anything can be used, either ringer lactate or ringer acetate. But large amount, then the lactic acidosis, and because acidosis will maybe there in burn patient, they are dehydrated, their perfusion may be impaired, and their liver function may be impaired. So there the lactate overload may be challenging, and where acetate will not have any such problem. But otherwise, largely they are similar. Their concentrations are similar.
Good evening, sir.
Sure.
Hello.
Yes, I'm listening.
Yes, sir. Good evening, sir. Sir, so in case of that post LACS goes into the DIC patient and went into the septic shock related AKI,
Yeah.
and we have replaced the crystalloids, blood product and all, and with the creatinine is baseline like 1.8 to 3. So how we have to manage with the fluids in this case?
Just. So you're talking about post LSCS DIC
Yes.
and post LSCS DIC and patients having impaired kidney function.
Yes, sir.
So in this patient, fluid management.
Yes, sir.
Okay. So uh, again we have to see. So since it is, this patient is very
And patient
complex.
is sorry, sir. Patient is already received so much blood and blood product,
No, that's what I'm telling.
plasma,
That's why I'm telling
PCV,
you
everything.
this. I'm telling you this patient is the most complex situation. Now, in this patient, everything will be guided by laboratory finding and physical examination. Like our most important goal will be to maintain hemodynamics, because
Okay.
this patient, like you said, post LSCS patient having DIC and
Okay, sir.
kidney failure. So likely this patient will have impaired hemodynamics also, because large volume has gone, lot of blood loss
Yes,
has gone.
definitely,
So
sir.
this patient will be having impaired hemodynamics. This patient maybe having overloaded lungs, because since lot of fluid which has gone, that fluid would have gone into the extracellular space also, and the
Yes, sir.
lungs probably will be heavy, and immunomodulation would have happened. This patient may be having some kind of capillary leak or all those things. So there will be respiratory work of breathing may be more. Patient will require higher oxygen, and hemodynamics need to be maintained. So for this, we will need perhaps at least once central venous pressure monitoring, if not arterial pressure monitoring, at least one central venous pressure monitoring, because that will help us to know the volume status of the patient.
Volume status. Yes, sir.
Now, after volume status, we will need Foley's catheter, which will help us to know the urine status of the patient. And then we will need to do at least either laboratory test for sodium potassium, at least sodium potassium, otherwise sodium potassium and magnesium, either this, and preferably ABG, blood gas, because when you are telling me post LSCS DIC patient going into AKI, this all will happen in a time frame of 24 to 48 hours. This is very rapid. So that is why I'm saying, I'm rest of things I'm assuming that patient will having a respiratory issue, hemodynamics, and we need to do a blood gas which will tell us what is the pH of the patient, because pH also would have changed because of
Deranged.
large
Yes,
volume.
yes.
So
Yes, yes.
pH, bicarbonate, base deficit, lactic acidosis, and most importantly, we will need to do a because thromboelastography will tell us a patient of DIC is very challenging, because DIC means patient has gone into consumption.
Yes.
Now,
Peripheral consumption.
if you give blood and product, the DIC will continue. So perhaps, uh, as I said, I am myself not a hematologist. In this type of situation, I will manage patients, as I said, with oxygen or a non-invasive blood pressure,
Okay.
at least one central line, if not arterial line, Foley's catheter, and ABG thromboelastography. And I'll definitely send one sample for the at do X-ray chest. I will manage send a hematology reference. And in the interim, if the patient is not having hyperkalemia, I will continue with my balanced crystalloid solution, and we will give albumin. We definitely no starches can be given. Hydroxyethyl starch is contraindicated. It is absolutely contraindicated. Should not be given. We can use albumin, but the problem with albumin is even albumin. Now this patient who has DIC and AKI will be in a highly inflamed state. So please understand that crystalloid and albumin will have a similar volume effect. When albumin will leave the intravascular compartment very fast because of increased capillary permeability because of inflammation. But still, historically and traditionally, the clinicians use um, albumin. So perhaps I will also use albumin. We will use albumin in uniform doses of 10 ml or 20 ml per hour. I will not use FFP unless it is indicated by thromboelastography, because FFP will be counterintuitive. It will cause trolley and other lung injuries. So as I said, our best bet will be crystalloids, isotonic balance solutions, and our albumin, blood depending on hemoglobin, and other products depending on fibrinogen level, TEG. But in this patient, and we may need to use a small dose of heparin. Heparin sounds counterintuitive because patient is having DIC, but heparin can decrease coagulation and thereby decrease. And most importantly, this DIC is a result of inflammation. We need to control inflammation. There may be a role for steroid, or in extreme, and we should send procal if the procal is very high. We need to go on.
Need to step up antibiotic. Yes.
We'll give antibiotic. Actually, I want to know procal, because if we get a procal of 80 or 100, we may need to use some cytosorb, or to like some adsorbent to remove the inflammatory mediators from the blood. It all depends on the what degree of
Yes.
what severity of illness we are seeing. So as I said, you have thrown the most complex and most challenging patient at me. So it is the choices. The answer will not be about what fluid,
Yes.
but we'll have to look at the entire patient, entire picture of the patient.
Yes. Absolutely agree, sir. Thank you so much for answering my question and satisfied me. Thank you.
Thank you.
Thank you, Dr. Twinkle, for asking the question, and thank you, doctor. I have again dropping the chat registration link in the chat box.
Vijay, can you hear me?
Yes, doctor, I can hear you. I can hear you.
There is a question in hypovolemic shock. Saline is better or ringer electric? I'm trying to. I'll answer this question.
Yes,
Uh,
doctor, please.
so, hypovolemic shock, I think we should be using balanced solution. And when I say balanced crystalloid solution, it is either ringer lactate or ringer acetate. Uh, in fact, we should use ringer acetate or ringer like acetate or gluconate, not even ringer also. Saline, I'll be honest. There are no RCTs. There are no RCTs which show any difference in survival. So we can, if we go by evidence-based medicine, we can use anything: normal saline, ringer lactate, or other balanced solutions. But uh, like as we say, absence of evidence does not mean that evidence is not there or that fact is not there. We simply have not done enough studies, but intuitively and as per theory, it makes sense that if we use large amount of saline, it will cause a large extravascular volume expansion. The sodium concentrations may go up, hyperchloremic acid, chloremia may happen, acidosis may happen. So balanced solutions should be preferred. And this is what my thought is. And in today's medical practice, most of the clinical centers, people have shifted to ringer lactate, and more importantly, balance crystalloid solutions. But at the same time, I will be honest in admitting some very high centers and traditional centers still continue using normal saline. So the jury is out, but this is what I will do. And if the hypovolemic patient is a CKD patient, then my answer will change. Then perhaps normal saline may become a better thing, or we may use a balance of both. So this is what I would like to say.
Thank you, doctor. Thank you so much.
Sure.
I think we can end the
There
day,
was
doctor.
some, there was some question about alcohol. There was one more question. I'm not getting it. But if you can see any question, please ask me, or otherwise.
Yeah, there's one more. I think this question, Dr. Gautam is asking, sir, in
Burn. There's a question about RL in burn. So this is what I said in liver injury. Yes, I think I have answered that question.
Okay.
There's one about.
Great,
Okay, so is it better to use ringer acetate in chronic alcoholic patient? Uh, I really don't know. The chronic alcoholic, otherwise ringer acetate will not make much. If the chronic alcoholic patient is having any liver injury, if the liver function is deranged, then it may make difference. But if the liver is normal, then perhaps it should not make any difference. Then ringer lactate will be as good. Yeah.
Nikita Sharma is asking, in diabetic patient, which is better, RL for NS?
In diabetic patient, RL or
NS.
actually only diabetic patient will not make any difference. My reasons for using ringer lactate or balanced crystalloid solution will be same, and I will in diabetic patient also I will use this. NS we will talk only if the diabetic patient is also having kidney disease, because most of the diabetic patient, long-standing diabetic patient, are likely to have kidney impaired function of kidney. If my creatinine is high, if there's a patient is known patient of CKD, in any such situation, I may switch to saline, as I said. But if hyperkalemia is not there, if patient is not having any kidney injury, if hyperkalemia is not there, then balanced crystalloid solutions are always a preferable solution. But if the patient is having a kidney disease and hyperkalemia is not there, still balanced crystalloids are there. If patient having kidney disease, decreased urine output, and risk of hyperkalemia, we may consider normal saline.
We have one more question, doctor.
Sure.
If you can scroll full down, there is two questions.
Sir, post CABG with diabetes mellitus and CKD patient. So, okay, same answer. Post CKG with diabetes, this is a patient with like diabetes. We want to use NS or so same. My answer will be same. We continue using balanced solution in post CBG. Post CBG patient, number one, I will continue using small background flow of dextrose, as I said, and then that will be neutralized dextrose, neutralized sugar, 5% dextrose, and in CBG patient we monitor ABG, and we are very well aware of our portal electrolytes. So we'll continue using balanced solution. And if my patient's urine output falls and as potassium goes up, then I may consider switching to normal saline.
Thank you, doctor.
In CKD patient, what fluid? I think I've been answering this question in previous questions also. And dose there is no dose actually. Dose depends on patient needs. Patient is fasting, patient is losing blood, patient is of burn, or patient is having dehydration. So the answer will come from there.
Okay. Great, doctor. Thank you so much, doctor. Thank you for all for attending the session, and thank doctor. It is really privileged to have you on the session, and it gives me immense pleasure to greet you today, and thank you so much connecting on a Sunday evening. And I know on what kind of situation you are in. You have a patient waiting in the ICU, a critical patient. But thank you so much. Thank you so much for joining, and thank you so much for explaining on a topic. And doctors, thank you for joining today on a Sunday evening. Thank you so much. Good night, all.